All right, good afternoon again, everyone. We're going to get started in just a minute. Just as a reminder, thank you for joining us today for today's webinar, which is Raise the Bar, Clinical Communications for Hospitals and Healthcare Systems. During this webinar, myself and Dr. Habash are going to actually share some insights around our Everbridge's solution CareConverge and some of the success that's seen in the market today, so we'll go through that. But just before we dive into that, a couple of housekeeping items just to keep you up to date. So first, there will be a Q&A session at the end. If you'd like to submit a question, you can either send your questions, you can basically type them into the open text field in the questions panel, and then we will go through the questions at the end of the session. We will also be providing links to the recording of the webinar and slides following this webinar today to all those who attended. And if you don't already do this, please feel free to follow us on Twitter at Everbridge to keep up to date on this and other topics that Everbridge is regularly covering. And with that being said, I think we'll dive right into the content for today. First I'd like to introduce Dr. Habash, who's the Chief Medical Officer for Everbridge in our healthcare solution area. And then my name is Chetwynd. I'm the General Manager for Healthcare Solutions here at Everbridge. We're both excited today to share some of the newest things that Everbridge has been working on in the clinical space and some of the experience we've had with healthcare customers. So just a little bit of background for those who aren't as familiar with Everbridge. Everbridge is a global communications company, and we offer a number of solutions on a common communication platform to handle issues ranging from emergency management, such as hurricane response, et cetera, to IT operations issues, and then, of course, very relevant to today's conversation in the healthcare arena as well, where we work with a number of health systems across the U.S. To help manage critical communications. We deliver over 1.1 billion messages were delivered in 2015 across our platform, and maintain contacts and communication paths with over 100 million individuals across the globe. And built on that structure, Everbridge is actually recognized as a leader in a number of areas. Gartner, which is what we're listing here, is essentially one of the analyst organizations that tracks IT technical solutions in the marketplace, including communication solutions. Everbridge continues to be recognized in a number of categories. The upper right-hand corner is where leaders in those categories are recognized. And we continue to strive towards maintaining that leadership across all of the solution areas that we help solve, from emergency management, again, to IT operations, to clinical communications, to safety applications. And really, just to give you a little bit of breadth on those different solutions, as I mentioned, we work in healthcare, we work in government, state and local government, and we do a lot of work there, as well as with corporations, businesses, higher education institutions. You can see we offer a variety of solutions across this platform. And really, our solutions vary from high severity emergency situations where communications really have to absolutely get through to individuals. And those, based on those communications, people's lives and safety are on the line. Certainly healthcare is one of those areas where we do work like that. All the way up to very frequent communications where we offer operational efficiencies. So another example from healthcare is we also work with a number of individual institutions for things such as nursing staffing call-outs, for example, where it's more of an operational type of challenge to the institution. All that is done across a common platform, providing efficiencies across that platform. And so in healthcare specifically, so we work, as I mentioned, with almost 3,000 customers across the globe. We have about just over 800 of those are in the healthcare space. You could see some of the healthcare systems and hospitals that we do work with across the country today. And we work in a variety of ways, everything from emergency departments to inpatient settings to home health agencies, skilled nursing facilities, and et cetera, offering up various communication solutions. And when we talk about hospitals and healthcare, we really focus on three key areas. So the first area is we have a large presence in safety and security. So in most health systems, there's individuals who are tasked with emergency preparedness, and Everbridge is the leading platform in that market space today for communicating such things as when a hurricane occurs, a natural disaster, a chemical spill, and really providing for the safety of employees and patients and families and et cetera who are operating in and about the hospital in reaction to those kind of incidents. We also do communication work around IT operations for critical systems, everything ranging from EMR downtimes to when a refrigerator with medications might go out, for example. And we provide alerts to IT and maintenance teams basically to rapidly respond and collaborate around resolving those issues in a timely fashion. And then the last area we work in is really clinical care. And we list the emergency department here because it will really, in some of our examples today, we'll talk about a lot of the work we do around that department, but it really applies throughout the hospital as to supporting various types of clinical communications that really both impact, obviously, operational efficiency and cost, but more importantly, really provide better care for patients. So with that said, I'm going to walk through an example of one of the ways that we work with hospitals today, and really how our solution itself actually comes together and brings multiple capabilities to really resolve clinical workflows. So one area that we work a lot in is emergency departments, and one of the reasons for that is really there are a lot of high acuity critical communications that have to happen, obviously, around an emergency department when patients are coming in, as many of you probably know. And the costs and impacts on outcomes there are very significant. One area that we do a lot of work in today is around strokes and heart attacks and et cetera, these high acuity cases. And really, you know, across the United States today, there's a significant cost differential for the time needed to respond to those types of cases. So those are measured quite often in things like door-to-needle times as to patients receiving stabilization for a stroke, or door-to-balloon times for STEMI patients. And it works across the board for trauma and other kind of rapid response scenarios. Another big challenge facing emergency departments is really emergency department throughput. And, you know, I'm sure as many of you know, most emergency departments across the country are overcrowded today or over capacity. And that leads to a number of issues. One is obviously it significantly impacts patient care and how quickly patients really can be managed in that emergency department setting. But it also really impacts your ability to take in new patients, right? So things like diversion hours or patients who come in with less high acuity issues and leave without being seen at all. And so those can have both impact, again, on those patient outcomes as well as financial impacts from a hospital healthcare system perspective. In the last year, we do a lot of work around sort of Joint Commission challenges and Medicare, et cetera. And when we look at emergency departments and communications and how that really plays into some of these challenges we're talking about, the Joint Commission, as many of you probably know, measures sentinel events such as deaths and other severe outcomes within a healthcare setting. And in their most recent release, they're indicating that 37% of those sentinel events are really directly attributable to communication and or assessment failures. So rapid response, ability to communicate well, to assess patients, diagnose patients, and really act on that patient care. And that really serves as a backdrop to how to our CareConverge solution. So what we've done in response to this, and really from feedback from clients, is put together a number of capabilities at Everbridge and add some additional ones really to address some of these issues. So the story, just as a backdrop to this scenario, this is based on a stroke patient who is inbound from a home. And so in the pre-hospital stage of that patient's episode, we have our paramedic, our EMS team, who's essentially over the Everbridge mobile communication platform, indicating notifying the ED of that inbound patient. And so you can see the information shared here. We have picked up our 39-year-old male, responsive to verbal, 8 breaths a minute, et cetera, with an onset time of 11:20 p.m. On this same platform, we have our triage nurse who can immediately respond to that, again, all across this mobile platform. In addition, the nurse actually could be sitting at a desktop. We have multiple ways that they could communicate. She essentially takes that information and notifies our on-call ED-MD, who's working tonight. He responds in and decides that they need to do a consult request for a neurologist. And so we have him reaching out on the same platform, and actually he's asked the triage nurse to reach out to our neurologist. She basically, with a click of a button, is going to reach out and request a consult. Now, behind the scenes, what's happening here, and we'll share a little bit of this as we go through, that request is actually looking at who's the on-call schedule directly for neurology tonight, who's on call, and then also providing the ability for that neurologist to respond over multiple devices. If the neurologist doesn't respond within the given window, it automatically escalates. So this deals with a lot of the issues that might happen when we go down to the PBX operator and trying to escalate this to get a neurologist on the phone. Our neurologist responds directly. Oh, please do. Yeah.
Sorry, I just wanted to interrupt.
Thank you, Dr. Habash.
Yeah, of course. Yeah, everything you're saying is perfectly true. But I just want to, reiterate the importance of this, because when someone calls for a consult, it is not just a text. It is usually they call the answering service and they have to wait for a call back. And that process alone can take maybe 10, 15 minutes itself. And so, just the prospect of being able to text back and forth and in a group message and get a confirmation or a read receipt from the neurologist or from whoever's taking care of the patient, that is invaluable, because it is shaving time off of this door-to-needle time and helping us, triage the patient a lot faster and get orders started a lot faster. So I just wanted to, punctuate what you're saying, Eric, by saying that.
Yeah, no, thank you, Dr. Habash. That's a fantastic addition. And in fact, a number of the clients that we're working with are really focusing on exactly that issue of altering their workflow to get those benefits. So that's really helpful to hear. And just working beyond that, so now once we have the physician, our neurologist respond, right, and really shaving that time off the system, there's another savings that really happens here across a communications platform like Everbridge, and that's we can actually do the assessment directly over the platform. And so in this case, our neurologist, it's at night, right? So we're at 11:50 at night. The neurologist is not necessarily sitting at the hospital, and so he can now communicate directly to the EMT team who are still on the ambulance with the patient, and essentially do a video consult directly over the platform, where he can assess the patient in real time and conduct his stroke assessment to determine the next course of action. And, I think as Dr. Habash kind of mentioned, and we'll share a little bit of some of the places where we've done this in the story, having that sort of real-time visual assessment where you can be able to communicate directly both to the patient and the EMT in this case to do that assessment prior to the arrival at the ED. It also shaves additional time and really provides that ability to do that kind of face-to-face consult. Anything you'd like to add there, Dr. Habash?
Yeah, definitely. So, what I want to again just highlight is the fact that the NIH stroke scale is not usually done in transit. That we have to wait for the patient to get to the ER, get through the door. We call the neurologist who has to come in. I mean, imagine the time that you're saving there. It's insane. And even if the neurologist is using some sort of a robot or whatever on the other end, there's still, even if he has to get to a desktop from his bed, for instance, something like that. I mean, that's a lot of time saved when he can just flip open his, mobile device, smartphone, and do a quick FaceTime-like video call to triage a patient while they're still in transit and get everything started before that patient has even touched ground in the ER.
Yeah, no, that makes a lot of sense. And actually, and based on that exact scenario, he can then also immediately call for whatever the next step in the process is, right? And he's got the whole team essentially already in the communication path with him. So in this case, in our story, he's going to call for a CT scan and to fast track that patient directly down to radiology when they arrive in the ED. Based on that, again, our triage nurse in our scenario can call for a fast track. That fast track across the Everbridge platform, again, based on on-call schedules, can essentially notify everybody on the team, and we just have a couple of examples here of our radiologist and our ED nurse, but everybody on the team who now needs to take action around that stroke code. You can see on the left-hand side that can include our lab techs, it could include pharmacy, it could include our HUC to begin orders. So all those folks can respond directly and start to take the next steps in the process, all in this one communication stream. In our story here, we're going to actually now run our diagnostics, and those diagnostics in this case are the CT scan. So once the patient, Mr. Thomas, arrives at the hospital, the patient is directed directly down to radiology, and they run those scans, and then they're able to actually publish those scans directly into the conversation, because again, our neurologist is remote, and so he could still be working at home. He can review those scans directly online and make the call about the type of stroke that's occurring there, what the next step is.
Even if he's not remote, I mean, just,
yep,
sorry,
good point.
Even if he's not remote, that doesn't even matter. It's the time that's spent logging into the DICOM unit and scrolling through images and whatnot. You know, when you can get an image that's pertinent texted to you right away and make that determination, that's invaluable.
And based on that, getting that rapid response to that image, he can make the call to, in this case, administer TPA. And we can have, in this, again, whether he's on site or he's remote, he can have that administered, which really leads to our outcome. And then in our example, we had him remote, where the ED nurse is going to administer the TPA. In our scenario here, we have 53 minutes in time since onset of the treatment. In most cases, most folks are really measuring door to needle time for a stroke, obviously, and in our scenario, that would have been about under that 30-minute window for that. And I know Dr. Habash is actually going to share some actual examples from clients where they've had that kind of a significant impact on that door to needle time. So I wanted to just share, kind of give you a little background. I think it's best to see the application, kind of the solution from a workflow perspective. A lot of what we've shown here is also applied by many of our clients in other high acuity cases, such as a STEMI, where you might be activating the cath lab, for example, trauma patients, where you might be bringing in outside trauma specialists or trying to get a hold of that surgeon to get that secondary consult going. So a number of scenarios that this plays out in. And the other piece that's really key here as well is that we can close this out, so it's a closed loop system. So even though from a clinical perspective we've actually administered the TPA, and obviously from the clinical team there's going to be a handoff most likely to the interventionist, but when we look at the end of the scenario, we can actually have our administrator come in and close out the scenario, and that actually creates all our reporting in the background, so we can actually look at what the response times were, and then over time look for improvement opportunities across the system. I wanted to share one more example, just from more of a from a back-end perspective. I know a number of healthcare systems actually obviously have PBX operators in place, and this might actually be a call down to that team, and we certainly work in a scenario like that with a number of folks as well. And so behind the scenes, that's as simple as, in this case, we've chosen a STEMI response, but essentially putting in a couple pieces of information, launching that, and all behind the scenes, as I mentioned, that runs through the on-call schedule or on-call schedules for each group to figure out who's on-call needs to respond. And again, we shared that it communicates over this secure messaging platform so the team can actually confirm directly there. In fact, it also escalates to other devices, so it could be, you know, pager and et cetera. It's a multimodal solution. And then probably just as importantly, from a launching the incident perspective, you can then track your responses. So both from reporting at the end of the day, but if you need to really track, for tracking in real time, we have a complete dashboard for tracking those responses. So for example, in a cath lab, if you have to have 3 people to activate the cath lab, you could track that there are 3 individuals that have actually responded to that in real time, and that would notify the operator in this particular case. So I just wanted to show, you know, a little bit of a different angle of how this overall solution kind of comes together to not only coordinate with our clinical team, but actually the support team that's behind the scenes for the clinical team. And with that being said, that kind of introduction to CareConverge, we want to walk through a couple of stories, sort of our case studies that we've done with some customers and some of the success that they've had. And so I'm actually going to turn it over to Dr. Habash to share some of those with you.
Sure, thank you, Eric. That was great. Okay, so you know, I know that time savings and ROI and patient outcomes is not really lost on this crowd of ours, but I'll start from the beginning of what we did with Mayo Clinic. There was a statistic that I read where 85% of patients who call 911 are actually never admitted to the hospital. So what does that mean? It means that they just needed help getting off the toilet or to figure out what medicine to take next or whatnot. And it's non-acute issues, basically. So the problem is that that's taking away resources from patients who really do need them, the cardiac arrest patients and the stroke patients, which are even more critical. So what we did with Everbridge was we worked with Apple and Verizon and then approached Mayo Clinic to see if we could just put iPads on their ambulances and see if it was feasible to do the NIH stroke scale from the ambulance, kind of like what we just talked about. It turns out it is feasible. So we just stuck an iPad in the ambulance and had the EMS call the on-call neurologist through Everbridge and do a video call just like we talked about. And the NIH stroke scale was able to be assessed in transit. The door-to-needle time, you know, the time savings was about 7.45 minutes, which doesn't sound like a lot, except the fact that a stroke patient loses 1.8 million brain cells per minute. So when you multiply that times 7.45 minutes, it's the difference between a patient walking out of the hospital and being wheeled out. There were decreased lengths of stays in the hospital, decreased complications. The whole team was able to be called in immediately. The orders were able to be started. ORs were prepped. I mean, things just ran a lot smoother because, once again, we didn't have to wait for the patient to touch ground in the ER to start that entire process. Now, we went one step further to compare our little solution with an iPad mini and our software on it, which ended up being about a $285 setup, versus the $1.5 million telemedicine robots in the mobile stroke units. And it turns out the telemedicine robots actually add 8 minutes to the door-to-needle time. They add time. And the reason they add time is because they're very cumbersome to use. So imagine the neurologist having to get out of bed and get to the robot and turn it on and start moving it and controlling it that way. It actually added time to the whole process. So the delta was 16 minutes of savings of time and $1.5 million of savings. And then I love this line: lives and brain cells saved. That's priceless. You know, you can't really put a price on this. Not only is this just so much better for everyone involved, but obviously the patient is the biggest winner in this whole scenario. But once again, we can go through, you know, the ROI too, because I know that really resonates with a lot of the folks on this call. I mean, every day that a patient stays inpatient, it's about $1,300 a day for a patient to be on the floor, and about $7,500 a day for a patient to be in the ICU. So when we can save any day of time, we're saving, you know, hundreds of thousands of dollars for the health system and for the patient and the insurance companies as well. I mean, it's a no-brainer. It's just a win-win all the way across the board. We can go to the next slide. I think that's a lot for the Mayo project. Oh, I will add finally that the results of that study were published and presented at the American Telemedicine Association by the Mayo Clinic. In this next slide, you know, basically what we're saying is, you know, telestroke, telemedicine, those all used to be pretty novel concepts a couple of years ago, but now they're just much more prevalent. 72% of hospitals are using some form of telemedicine, and 52% of physician groups. So now, if you're not using telemedicine, telestroke, or anything, you're a little behind the curve, and we can help you get with the program. All right, we'll go to the next slide, please. Great.
So So let me just start this one off, Dr. Habash, and then you can comment. I think it's very similar to what you've been highlighting. So we've been working with another system. This is Renown Health out in Nevada, and essentially they're doing a very similar thing to this combined story, where they're running their code alerts through this process that we just shared with you. And as you can see here, they got, and we talked about this faster response time. They saw significantly faster response times, which obviously impact that patient functional outcome. So in addition to the cost savings really impact that downstream. And those, again, similar to what Dr. Habash just shared, really equate out to shorter stays and reduced post-acute care. And you can see kind of an estimate of their savings from that particular story. So I think we share this one because a very similar story, and not necessarily just tied to the telehealth, but just really connecting the whole process for better managing those patients from pre-hospitalization all the way through the ED and to the handoff can have a significant impact on those patients. I don't know if you'd like to add anything to that, Dr. Habash.
No, I think that's a good segue to the. I'm not sure if the next slide is about the ED time. Okay, good. All right, that's a great segue. So, so one of the things that that happens in a hospital system is there's a CMS core measure which dings hospitals on ED throughput time, and that is the time for a patient to sign in to the emergency room and then either get admitted or discharged. So that time can take hours sometimes, and most of that time spent is just trying to get in touch with the consultants and the admitting physician and the nurse or the radiologist or whatever it may be. But it's all about communication, and that hurts the hospital systems when they're trying to meet their core measures. So we did a little study. It was kind of an informal study in one of our large hospital systems to see if the simple secure messaging, which included video triage as well, and not pre-arrival triage. This is when the patient is in the ER. And for me, for instance, I'll just give you an example. I'm an ophthalmologist, and I get called 10 times a day to come triage a patient from the ER. Obviously, I'm in clinic. It's really hard for me to do that. They have to wait. My staff has to wait for me to get out of the patient room before I can return the call to the ED. What happens then? 10 minutes later, nobody's there anymore standing by the phone waiting for your call. So by the time someone gets on the phone who knows what's going on with the patient, 10-15 minutes has elapsed 10 times a day. And that's a huge time sink in my day, and plus that adds up for the ED physicians and for the patients as well. So that's really what backs up the ED throughput time. In our study here, we just wanted to see if better communication just via a mobile device on secure messaging and video could help save the ED throughput time. And it did. It saved 48 minutes from that patient's ED throughput time. So not only does that meet all the core measures, of course, but imagine the efficiency through the hospital system. Every single time you're saving 48 minutes from a patient's triage time.
And on I think our last example here is really more of an operational kind of example, but really also another, again, actually Renown Health, another customer we're working with here, will again leverage some of the same capabilities that we're talking about to better manage not only communications and callbacks for clinical staff, but really focusing on patient satisfaction as well. And so in that particular scenario, they augmented not only their clinical communication with this callback feature, whereas when patients would call in to ask for a callback from a hospitalist or specialist, rather than go out to a third-party answering service or doing just a pager and then sending the number and waiting for that callback, they're leveraging the CareConverge platform to essentially reach out to those clinical staff, get them to share the information about the patient, which can include PHI because it's on this secure platform, and then even provide automated escalation. So if those clinicians, depending on the severity or the urgency of the call, if those clinicians were not able to reply in a timely manner, it would automatically escalate to the right clinician, again, based on call scheduling and escalation rules that were built in. And they built that kind of closed loop process to make sure that those patients were receiving a call back in a timely manner when it was appropriate. And you could see some of the savings that they really looked at here. They were actually able to eliminate their third-party service, which saved them about $120,000 a year from an estimated perspective. So we share that to show that, again, when we're talking about clinical communication, there's not only that direct clinical communication that happens on the floor, but there's obviously a number of different places where we're enhancing that around the CareConverge platform for more of operational or day-to-day kind of challenges. All right, we're going to jump on for a second here. So we talked a lot about CareConverge and kind of introduced some of the capabilities across the platform. We thought it would be helpful just to kind of give you an overview of, okay, so what is in this solution that we're talking about? You've seen lots of different components here and some customer success stories. The first component that we talked about a lot about is really we have secure care team collaboration and teleconsult capabilities. And so, I think you saw our mobile solution as we went through, which is Everbridge, which is the solution we use for mobile communication, which obviously works on, any smartphone, mobile device. But we have other multimodal communication methods, again, working across 100 different modalities for notifying individuals about critical messages. The communication that does happen on the platform can be via image, audio message, texting, you name it, can happen. And then there's also a companion desktop solution as well. So in many hospital scenarios, we work in a multiple kind of communication methodology where some folks are mobile, some folks are on desktop, and sometimes they mix the two depending on the time of the day. And so all that's supported directly across this solution set. And then we also have Care Events, which is our automated workflow components. And really, a lot of what we shared today for customers such as responding to a stroke or responding to a STEMI or even the callback notifications are really managed through our Care Events, and then we're going to talk about our dynamic care team management capability as well, which can all be tailored to your specific healthcare system's needs. So it's a complete workflow rules engine, which allows you to customize how you want to respond to specific events. We can also obviously provide services around that as well, and then provide you all the reporting back out on timed responses and how many of those events have you had this month, how are folks responding, et cetera. And really the last element that works tightly with those care events is our dynamic care team management capability, which is really primarily on-call scheduling. And then we have a robust on-call scheduling platform, which really allows for both tracking who is on call, multiple shift capabilities, including shift rotations. You can assign shift quotas, et cetera. And then automated escalation too, based on response time. So based on a specific care event against a specific sort of care team schedule, you can escalate those responses to make sure you're getting the right people to respond in a timely fashion, depending on the severity of that event. We can also, we have our complete scheduling platform, but also can integrate with other scheduling solutions as well. So if you already have an on-call solution for some departments, that can actually be integrated directly in. And then lastly, that's all built on the Everbridge core platform. And that platform is a completely secure platform, so fully HIPAA compliant with triple encryption, audit capabilities for conversation history, the ability to do mobile device management, either via a standard mobile device manager or actually built directly into our platform. We have a lot of those capabilities like remote wiping and locking accounts, et cetera. And then data retention, you can retain secure storage for those conversations for up to 7 years. We also have a complete integration platform, so we can work with both from an Active Directory as well as single sign-on, as well as EHR integration, which we're starting to work on with a number of clients around things such as new patient notifications or discharges, lab results, et cetera, can all come across that same platform. And then, of course, we have a complete service component as well, including implementation services, ongoing health checks, rollout services, et cetera. So I think that's all the information we had to share with you today about CareConverge. We're going to take just a minute and just compile some of our questions. All right, just taking a look through the questions that folks have submitted today. We have one question here about texting orders, and maybe this is a good one for you, Dr. Habash. Do you know if the Joint Commission allows texting of orders?
They came out with a rule in September that allowed it, and then they took it back. They actually didn't take it back. They just put it on hold for a while, and now it's trickling through again. So, yes, texting orders would make our lives so much easier, and, you know, JCO understands that now. So it is back in action now. They're trying to be very careful about, like, what's texted, and they're trying to make better parameters around, you know, what kind of orders can be given. Can pain medicine orders be given versus, you know, surgical orders or whatever. But yes, for the most part, texting orders like, you know, patient okay to eat now, or, you know, change to soft diet, or okay to discharge. Those are things that can be texted now.
Great. And I think one of the correct me if I'm wrong, Dr. Habash. I think one of the caveats there, it has to be on a secure messaging type solution. Just to clarify for those who might be thinking of the standard texting, I don't think the Joint Commission allows that. Right?
No, I'm glad. Yeah, that's a given.
Yeah, no, exactly. Okay, good.
We'll all lose our jobs. Yeah, we'll all lose our jobs for doing it the other way. But yeah, this is definitely a secure platform that they're talking about.
Fantastic. Let's see, the next question that we have here, I think there was a question about, we mentioned about incorporating information into the EHR. A couple of things that I'll just mention quickly about that. I think we just shared that we're working with a number of clients around taking information, notifications, kind of events out of the EHR and notifying through the mobile device platform. So you can envision where we were showing the communication path happening, the communication happening, that, you know, one of those communications, instead of let's say an EMT saying that I have a stroke patient with, you know, the following onset, et cetera, that it could be your lab results appearing directly in that conversation to you based on your patients. The other side of that, I think that's being asked here, is how do you incorporate that back into the EHR? We do have some customers who are looking at, you can export all the conversations. All the conversations can be saved off. So if you have a conversation about a patient, that can be downloaded and then shared back into your EHR, either via an integration or it can be stored in many cases. Most of our customers have been looking at sort of the document storage component. So depending on where that is, that's how that would work. The next question I have, there's a question about payment here, Dr. Habash, which I think might be a good one for you. You know, with the teleconsult capability that we just showed, how does that work from a billing perspective, payment perspective? Does that count as a face-to-face visit or anything like that?
Yes. So you can get reimbursed for a video call with a patient. It has to be real-time HIPAA-compliant video, which is exactly what we offer. From any device, it doesn't matter. But a lot of it depends on, you know, first of all, Medicare won't pay for these visits unless the patient is in a very, very remote area. In Florida here, there's like one zip code where they'll pay. So we don't really worry about them too much. But the private payers are the ones that are paying quite a bit. There are 32 states that have parity laws. And a parity law means that your state has a parity law. It means that all the private payers have to pay you for telemedicine, have to reimburse you for telemedicine. There are it's 32 states plus DC. There are 8 more that are in legislation right now. So clearly this is, you know, kind of sweeping the country, and we can count on the private payers to reimburse us for these visits. Medicare will catch on eventually, I'm sure. And there is a lot of lobbying going on right now for that. But just to give you a couple of practical examples, you know, again, I'm an ophthalmologist. Patients call in all the time with, you know, they'll wake up with a red, bloody eye. Do I need to come in? Do I need to go to the ER? Can you call me something in? Those really simple questions that we're already triaging anyway over the phone with very little information. All you have to do is connect with the patient via video. I just have them download the app, and, you know, within 2 minutes, we're up and running. My girls get them all set up. And I lay eyes on the patient with video, and I can tell them what to do at that point. Even if I tell them, no, you're going to have to come into the office, that is still a billable visit. But, you know, imagine the cost savings, time savings that offers the patient and to me. So I'm also not clogging up my waiting room with unnecessary visits too. So for all those reasons, I mean, it's a very big benefit to all my patients. I do it as well. I offer it for follow-up visits as well. And, you know, obviously you have to be careful about what you think is amenable to an e-visit or not. But let's use, you know, an example like a sty. I'm sure everyone here has had one. You know, you see a sty the first day, you know they're going to get better in a week for the most part, and they still need a follow-up visit. But hey, you know, it's a working mom, she has 2 kids at home, and it's impossible to lug everyone back to the office to sit there for an hour just for me to tell her the sty is getting better. So I'll offer that patient an e-visit where she can do it from the comfort of her own home, over her smartphone or tablet or desktop, and you know, we can have that visit. She pays her copay, and that's it. You know, these patients are willing to pay a premium for this service just to have this ability with their own doctor, someone who they know and trust and knows them, and where all the information is inputted into the EMR system too. So there's a good record of everything that's been done. So those are just 2 very practical examples. I think that for transfers, and that's a very important issue for the hospital systems. We get tons of transfers of patients. 50% of them probably don't need to be transferred. The other 50% needed to be transferred like 2 days ago. And so if you can elucidate those types of patients just with a video call to the institution on the other end of the line, I mean, imagine what you're doing for the patient and for the health system itself. I'll stop rambling about that now.
Great. No, that was fantastic. Thank you, Dr. Habash. I think it's a very good response to that. The last question that I see here today is there's a question here about physician and staff adoption and the challenges around that. And, you know, I'll take a quick step, and then I'll let Dr. Habash comment too, because I know she's had a lot of experience here. So I think like any new solution, particularly IT solution, you know, there can be team adoption challenges, right? And those vary from physicians to nursing to other staff in the hospital setting. I know we've done a lot of work on rollout and adoption programs. Really, a couple things there, just to really make it easy for folks to download and use the solution. So even though we've kind of gone through a lot of the rules and scheduling and et cetera, obviously from a clinical perspective, we've tried to make that solution very simple, and there's one device that you kind of work from. And then we have a complete adoption program that we run with most of our hospital clients to really help facilitate adoption across the board, which can include things like building out the workflows and figuring out the steps and et cetera from a nursing perspective, or just really engaging clinical staff. And I know, Dr. Habash, you worked early on with the overall solution around really trying to make it very easy to adopt. So I don't know if you want to comment to that.
Yeah, I mean, you know, it's very simple. Like, we don't have time during the day to fool around with logins and portals and you know, crap like that. So we need to be able to just use our phones and mobile devices exactly like we already do when we're texting our friends. Because otherwise, you know, the biggest competitor is just non-compliance, which obviously, you know, will gain huge fines for the institution and cost us our jobs. We've already been warned about that, you know, till they're blue in the face. So, so the important thing here is just to make things really seamless. And when the app was designed, you know, the whole point was to make it seem like you're not even sure whether or not you're in iMessage or whether you're in Everbridge. It has to be that simple. It cannot take more than one brain cell to use. Otherwise, no one will use it. And we incorporated all the features that you have in iMessage and FaceTime, including the dictation and the push-to-talk and the talk-to-text, and an encrypted video or encrypted audio call as well, because every once in a while you just need to get on the phone and talk. And so you don't have to leave the app to do any of that stuff. It's super handy. And that will increase adoption.
And that's certainly, I think, just to add to Dr. Habash's comment, that's certainly been our experience as we've rolled out across systems, that has really driven that. So, which is usually quite often a key challenge. I think in looking through here, I don't see any other questions that have been submitted that we can address this afternoon. So let me just take a minute to thank everybody for joining our call today, and thank you, Dr. Habash, for joining us as well.
My pleasure.
We will be following up. Thank you. Sorry. We will be following up with the slides, so you'll get a copy, a link to the recording today, as well as the slide deck to share. And certainly, if you're interested in learning more, we really just wanted to kind of give you an introduction to some of the work we're doing in healthcare today and how we're really collaborating with healthcare systems. If you're interested in learning more, please reach out to us and let us know. We'd be happy to give more in-depth conversations around specific challenge areas and even share, demos of the product if that's helpful. So I want to thank everybody for joining and enjoy the rest of your day. Thank you very much.